So now I invite Dr. Rajesh for introducing as well as for starting the program.
Thank you, madam.
Okay.
A couple of words from Dr. Venkatagiri, our national president.
Sir
is there?
Sir, yeah, I'm not seeing him, sir.
Yes, sir, please unmute. Sir is there.
Sir is there. ISA national headquarters.
Yes, okay. So I invite Venkatagiri sir for a few words.
Thank you. Good evening,
President. Using as well as for starting the program.
Good evening, President Shamsad, coordinators Binil, Rajesh, and I don't see Vijesh and Secretary Paul and everybody. Good evening. It is very good that Dr. Balabhaskar is here today giving a talk on blood conversion techniques. It's very important topic in every aspect. Dr. Balabhaskar need not get introduction, whatever subject to say, being an editor of IJA and has read a lot and all, any topic he can talk very easily and quote reference and all. It is, it's too busy also, even if, when I call him that many times because it's involved in so many academic activities, not otherwise I'm telling that. And lucky that we are having him. And next week again, we are having him at SAR Congress also, because he is more known for this ISA guidelines, because he is behind that and with a lot of guidelines which are very important. With this, I formally declare that the CME inaugurated, and hope everybody will enjoy the talk with him and get use of this. And thank you all.
Thank you, sir. Professor Balabhaskar, sir, is the professor of anesthesia at Vijayanagar Institute of Medical Science, Bellary. And recently we had practice guidelines on preoperative investigations, and sir was the chief architect behind many of the ISA practice guidelines. In fact, 5 recent ISA practice guidelines has come, like fasting, preoperative investigations and all. Sir was the formal national president of ISA as well as the editor-in-chief of IJA, and is an academician as introduced by Dr. Venkatagiri. And today is speaking about a very important topic like perioperative blood conservation strategies. Over to you, sir.
Thank you. President ISA National, Dr. Venkatagiri, thanks for the compliments and the introduction. Of course, without the support of our colleagues in GC, including Dr. Venkatagiri, who was the Secretary of ISA National, when the decision to take up the various guidelines was approved. So I thank him a lot, and also he continues to encourage me for various academic activities. Dr. Shamshad, President of ISA Kerala State Chapter. Dr. Binil, the immediate past Secretary. Dr. Rajesh, who is there as Scientific Chairman. And of course, I think Paul Duffel is set to join. And all the senior members of ISA Kerala, all the students who are gathered here, and all the faculty who are also part of this program. Thank you very much for inviting me and allotting this topic, basically. Of course, I did discuss with Dr. Rajesh about the topic before we could finalize this. So as you see here, the topic goes as perioperative blood conservation strategies. This is a topic which is actually very important, and students get caught in between. Because something alternative normal transfusion discussion, like the packed cells and the plasma and other discussions normally happen. But something related to blood conservation strategies is also very important. And it is for this reason we have picked up this topic for the day. All of us are involved in the surgical management of the patients. We provide anesthesia services. And surgery, by nature, it involves cutting of the tissues and there is always bleeding. But in more than 90% of the cases, there is no need for blood transfusion at all. Mainly because it is of a smaller quantity, number one, And even then, the body has got a capacity to compensate. For example, when there is a bleeding, we say there is a fall in hemoglobin. It's a sort of acute anemia, but the body compensates by reducing the viscosity, which causes a reduction in the resistance to the flow of blood from the heart onto the different tissues and also the venous return. There is an increase in cardiac output with increase in stroke volume, and there is an increase in oxygen extraction by the tissues also. And sometimes when we are not able to give fluids for the patient, body also is associated with increased sympathetic drive. There is an increase in heart rate and increase in cardiac contractility. So we normally don't need to transfuse blood. But in some situations, the bleeding is little bit heavy and it can be definitely be potentially harmful or even life-threatening, mainly because it could be an acute unexpected bleeding, or it could be purely because of the volume that is lost, especially in even elective cases. And the body may not have the time to compensate, or it can happen a little bit late. Hence, we still need to administer blood in some situations. For example, when we talk about major elective procedures, where with liver resection, major cardiac procedures, kyphoscoliosis procedure, multiple spine procedures, or emergency polytrauma. So these are some of the conditions we definitely would be required to administer blood products. But still, blood transfusion has never been that much safe, despite the advances seen in the field for so many decades now. It is still unsafe because the risk of reactions is always there, risk of transmission of infections is always there. And even now in modern world, there are reports of clerical errors in terms of transfusion of the blood to the recipient. And some sects, they don't want blood to be received into their body. And there are majority of the guidelines which say that there is no need for blood transfusion, and the indications have shrunken drastically over the last few decades. Plus, in addition, there is a concept called bloodless medicine and bloodless surgeries. So, which is also now sweeping across the world. So, there is a stress on the conservation of blood, especially in the perioperative period. So, that's the reason we are trying to talk about what is known as conservation of the blood in the perioperative period. So, overall, the idea would be to, for example, reduce the surgical bleeding as much as possible. Of course, it depends upon the type of the procedure, duration of the procedure, and sometimes the surgeon's ability to bring down the bleeding also. Secondly, we can always use drugs to promote clotting, or you can give drugs to improve erythropoiesis. So beyond this, the last two items are very important. We can conserve the patient's own blood by donation for later transfusion, or we can collect the blood that is lost intraoperatively as well as postoperatively so that it can be retransfused to the patient. So these are the broad things which we can be doing. Hence, these are classified into direct approaches and indirect approaches. Direct approach is preoperatively what you can do is, as I said, preoperative autologous donation. Autologous is patient's own blood. The second thing we can do in the preoperative period is acute normovolemic hemodilution. Intraoperatively, we can salvage the blood. Postoperatively also, we can salvage the blood that is lost from the patient. The indirect approaches would be the use of various pharmacological agents, the erythropoiesis stimulants, as I told you already, and use of some pro-hemostatic agents. So what we will do today in the next 25 minutes approximately, we will try to see that how the various approaches pan out. Sometimes more than one of the approaches may be combined together for the best benefit of the patient. The first one is preoperative autologous donation. What is the principle? The principle is patient's own blood is drawn days before the surgery. It is stored for transfusion during the surgery. So what is the advantage? Definitely the risks associated with allogenic blood, somebody else's blood, even though they are compatible or cross-matched. So there are a lot of risks which I explained to you. They are avoided. And how much of the blood can be drawn? So normally 1 and sometimes 2 units of the blood can be drawn from the patient himself or herself. But one important rider is that hemoglobin must never be allowed to go down below 11% before the donation. And the last donation from the patient could be up to 70 hours before the surgical day. So what are the practical utility aspect of this particular preoperative donation? As I said, it has to be collected days before. So when I say it has to be collected days before the surgery, it is therefore applicable for only elective procedures. And if there is a risk of postponement of the surgery for other indications, we should not try to do a preoperative autologous donation because that will go waste. And we can always allow for earlier donation so that you can store the blood and see that the patient's hemoglobin comes back to acceptable levels and the patient doesn't suffer from iatrogenic anemia induced by you by drawing the patient's own blood. So how we can improve the patient's own hemoglobin status is in some of the patients we can try to use erythropoietin. So the patient's hemoglobin improves and he can draw the blood or see that there is no deficiency of hemoglobin. Or in some patients with proven iron deficiency, we can always supplement iron for the particular patient. So in fact, this preoperative autologous donation was popular in the 1980s. So I will call 1980s as a golden period of HIV and the golden period of preoperative donation, mainly because there was a heavy risk of transmission of HIV, plus always there is a risk of allogenic transmission. So that was a time when preoperative autologous donation was widely used. But gradually the popularity of preoperative autologous donation came down because the HIV itself was greatly controlled. The pandemic came down. The risk of transmission also came down. And there was a growing evidence that the preoperative donation may be less efficient compared to intraoperative blood salvage in reducing the chances of allogenic transfusion rates, means receiving blood from other patients, other persons. And again, it is also found by evidences even lower levels of hemoglobin can now be better tolerated and there is no need for blood transfusion. So the current indication for preoperative donation or autologous donation is very few. Number one, where we can't use the compatible blood products, mainly because in some individuals, multiple antibodies or very rare blood types. And number two, patients who refuse to receive allogenic transfusion. Okay, for example, one of the sects of Jews, Jehovah's Witnesses, and where there is a requirement for more than 4 units of RBC transfusion for an anticipated major surgery, we can always get the patient to pre-donate and retain it for use in the intraoperative period. So that was about autologous transfusion in the preoperative period, and it happens days earlier. The second one is acute normovolemic hemodilution. Here the principle is multiple units of patient's own blood is drawn immediately before the surgical incision. Okay, the patient's blood is drawn and it is stored, and euvolemia is maintained with crystalloid or colloid. So you keep giving IV fluids to the patient so that his blood volume is well maintained. So the withdrawn blood is retransfused at the end of the surgery, goes back to the patient. The advantage of using this is this blood has got high hematocrit, there are a lot of clotting factors, functional platelets, and plasma proteins because it is so fresh. And number two, the blood that is lost intraoperatively is dilute with lower levels of hemoglobin and hematocrit and RBCs, mainly because you have caused hemodilution for the patient. And normally this is not a problem in healthy patients because even the patients can compensate for these changes. So the same thing is shown here in a small 1-minute illustration with respect to the acute normovolemic hemodilution. So for example, this is the non-blood component, that is the crystalloids and colloids which can be sent. This is the blood that is drawn from the patient and it is stored. And subsequently, this blood at the end of the procedure would be transfused back to the patient. While the patient's blood pressure, heart rate and everything or the blood volume is maintained with usage of the crystalloids and colloids. So this is the way the preoperative acute normovolemic hemodilution works. So however, when we choose the patients, we should be clear that the patient is otherwise fit because I said there is some requirement of compensation by the body. Overall clinical assessment must be done and physiological status also must be assessed. And the hematocrit, the estimated blood volume and maximum allowable target hematocrit must be calculated first. Usually the target hematocrit is about 25 to 30%. So what we can be doing is deciding on the volume of removal of the blood by using this formula, estimated blood volume into the difference between the initial hematocrit minus the target hematocrit divided by the average hematocrit. Okay, so based on this, based on the patient's weight at 8 ml per kg, you can get the volume that can be removed. And simultaneously, you can infuse crystalloids at 3:1 and colloids at 1:1 ratio of the volume that is drawn from the patient. So, what is use? Definitely, it will be useful if the patient has got a good preoperative hemoglobin levels. Very important, no? So, if you try to draw from a patient who has got low hemoglobin, it will be very dangerous. So, it should be an acceptable hemoglobin, and intraoperative anemia is therefore well tolerated. And number two, it can be also useful where large volume of blood is anticipated. So, it cannot be using in simple procedures. But again, I would like to stress that there should not be any problem with the compensatory mechanisms, especially cardiovascular comorbidity should not be there. So this was again very popular in the 1990s. Again, there was a risk of transmission-transmitted infections, which was quite heavy those days also. And it would also reduce the requirement of allogenic transfusion. So that was the reason it was very popular in 1990s. But again, its utility has come down nowadays because subsequent evidences have not been so supportive about the use of acute normovolume chemodilution. And they actually found, trying to do this technique, there was no decrease in the requirement of allogenic blood transfusion. And in fact, they said the acute normovolume chemodilution could be inferior to efficiently perform intraoperative blood salvage and a protocolized preoperative autologous donation, okay, which I told you already. So current indications for acute normovolumic hemodilution is very few. So it can be used in patients with multiple antibodies or rare blood types, just like what I talked about with respect to the preoperative donation. And in those patients who refuse allogenic transfusion or stored component therapy, such as Jehovah's Witnesses. So we talked about preoperative autologous donation days before the procedure, number one. Number two, we talked about acute normovolumic hemodilution, where you collect the patient's own blood just before the procedure and transfuse at the end of the procedure. The third one is what is known as intraoperative blood salvage. So what is the principle here? The blood which is shed from the surgical site is collected by direct suction from the surgical field into a reservoir, if you can see in this illustration. So normally there will be, for example, two catheters or cannulae. So one will carry the blood, the other one will carry the heparinized saline, so that the blood doesn't clot. Then it is taken into a cell saver and it is subjected to washing and filtration. So waste products are then removed and disposed of, and the washed RBCs is again processed for retransfusion to the patient. Okay, so this is an intraoperative procedure. And further advantages of this using this intraoperative salvage, it is useful because there is better retention of the red blood cells biconcave disc shape. Means it can hold the hemoglobin better and the RBCs and the oxygen better. And there are more levels of 2-3 DPG, ATP than the stored blood. So because it is fresh blood. Therefore, it has got better oxygen carrying capacity and tissue oxygenation than the stored blood. And in fact, the final RBCs, washed RBC that is going to the patient has got 60 to 70% hematocrit. So this is the advantage of using an intraoperative blood salvage. This is again a small illustration, if you can see. So this will be the various components. So we have the patient's blood, which would be basically picked up through a suction cannula that goes into a container. And then anti-clotting factors, in the sense heparin is normally added to see that the blood doesn't clot. Then saline is added and the whole mixture goes to the cell saver. In the cell saver, the waste products are removed. That includes the various debris, which I can show in the next few slides. And the RBC that is now obtained is retransfused back to the patient. So what is the utility? Intraoperative blood salvage technique has got major role in multi-level spinal fusion surgeries, cardiac surgeries, and major craniosynostosis procedures in the pediatric patients. Compared to the preoperative donation and acute normovolumic hemodilution, in fact, intraoperative blood salvage appears very superior, and we are able to recover more than 70% of the blood that is lost in the intraoperative period. And it is cost-effective and convenient, and it is even advantageous for emergency procedures. So, provided you got the kit, which is also available now freely in India, we can definitely use it. There is no need to talk about the preoperative donation, acute normovolumic hemodilution, and other things. and definitely can be used in those patients with high risk of significant perioperative loss. It's also suited for patients with low perioperative hemoglobin who cannot tolerate perioperative donation. Perioperative donation has got its own problem because it induces anemia and patients have to recover. And acute normovolemic hemodilution, again, it will cause some sort of dilution, reduction in the hemoglobin. Therefore, we can use it in patients with low preoperative hemoglobin. And of course, the same conditions, patients who are unwilling to consent to allogenic transfusion, we can use blood salvage. And it can be used in patients with pre-existing bleeding risk or multiple alloantibodies. But again, overall, there is a reduced usage of intraoperative blood salvage, mainly because of improved or changed recommendations with respect to the transfusion practices. We have all now gone into what is known as restrictive transfusion practices, bloodless surgeries and other things. And there is better perioperative optimization of hemoglobin levels with the use of antifibrinolytics. In fact, one of the PGs, she is going to talk about tranexamic acid today. Second thing is, if the salvage blood is heavy in terms of volume, and you use more than 50% of the estimated blood volume and reinfuse to the patient, that will result in dilutional coagulopathy without clotting factors and platelets, and it is very dangerous. And the second most important thing, which I'm going to discuss in 2-3 slides, is the contamination from the surgical fluid. So it's not just the blood that is being sucked out. There could be topical anticoagulants, urine, amniotic fluid, bacteria, and even gas embolus. So, for example, there is a lot of application in cancer surgeries. Initially, there was concern about the retransfusion of malignant cell debris, but it is no longer applicable nowadays because there are better devices, better mechanics involved in these devices, and it is said the malignant debris are better removed in the modern kits. And it has also been tried effectively in prostatic and gynecologic oncology, where urine and malignant cells have also, it's a concern that they will enter the circulation. Again, it is found that even it is cleared very perfectly, and even if it happens, it is not associated with significant increase in morbidity, mortality, or cancer recurrence. So we can still use intraoperative blood salvage in cancer procedures. Only thing is, we have to be sure that it is clearly filtered and it should be irradiated. But you should always avoid completely the intraoperative blood salvage in cancer procedures when tumor is ruptured. There are again further controversies in obstetric surgeries. It was said that it can result in what is known as anaphylactoid syndrome of pregnancy. So, obstetric surgeries is also one where we may face sudden acute severe blood losses. So there could be a possibility of alloimmunization or amniotic fluid embolism. So this is a concern. But again, with the application of leukodepletion filters, most of the amniotic fluid is removed, immune mediators are removed, and debris are also removed. And in fact, a large trial, which was published in 2017, where 300 obstetric patients were assessed in terms of 7 trials, there was no evidence of increased incidence of amniotic fluid embolism. And it is said that it is okay to use the intraoperative salvage in high-risk obstetric patients. So in fact, we can use in placenta previa, creta, placental abruption, or abnormal placentation. And you can also use in a patient where there is a risk of uterine rupture and there is a sudden acute bleeding. So at that point of time, we can immediately collect this blood and transfuse back to the patient. And of course, all the medical conditions which I said, if it is part of the pregnancy, we can use intraoperative blood salvage. So now we have learned about, I'm just reminding for the sake of PGs to understand, we completely understood about preoperative autologous donation. We understood about acute normovolemic hemodilution. We understood about intraoperative blood salvage. The fourth one is, the important one is the postoperative blood salvage. The blood is collected from the wound drainage. Okay, so for example, this is a wound drainage, it is collected. Again, in the immediate postoperative period, mainly in orthopedic procedures, cardiac procedures, thoracic procedures, and it is reprocessed for transfusion. Okay, so the whole blood is again taken into the filter, just like for the intraoperative blood salvage, and it goes to the salvage machine, it is washed, then the waste is removed, and the washed, the blood, collected blood from the drains is taken back and infused to the patient. And always see that the patient's compensation is well maintained and give steroids and colloids, volume expanded to the patient. It can happen in 2 ways also, the processing. Washing can happen. Okay, wash, it's called a wash collection, wherein the blood is centrifuged, washed, and resuspended as an RBC concentrate. And there is also what is known as unwashed collection, where only filtering is done before retransfusion, means you collect the blood and keep it. So you keep it at 4 degrees Celsius for about 6 hours and you can transfuse it, and it is unwashed. So just before transfusion, we can filter it. Or within the OT, so I mean within the post-operative period, we can wash it and use it by the side of the patient's bed. Advantage here is it can avoid dilutional anemia associated with fluid resuscitation for post-operative bleeding. Okay. So, for example, if a patient has got anemia and if you are administering crystalloids and colloids, it is going to create dilutional anemia. So, here we are going to transfuse the salvaged blood, but it has got lower levels of hematocrit of only 20 to 30%. Even though it doesn't result in much increase in the hemoglobin, it is going to reduce the risk of dilutional anemia, which results possibly because of the administration of crystalloids and colloids. So, only thing we have to remember is in post-operative blood salvage, hematocrit values are less, but it is still useful as compared to intraoperative blood salvage, where hematocrit goes up to 60 to 70%. So, practically, even though if you look at the literature, there is a lot of benefit, especially in multi-level spinal procedures of orthopedics. For example, unwashed blood, post-operative blood salvage is very useful in the post-operative period. You get it from the drain and re-transfuse to the patient. And in cardiac procedures, we need to wash. So it is called washed POBS, mainly because, there is the bypass machine which is used. There is risk of accumulation of inflammatory mediators, activated clotting factors are there, fibrin can be there, FTPs can be there, and there could be hemolysis. So many things can happen, resulting in renal damage, lung injury, or coagulopathy. So that's the reason we must wash the blood collected post-operatively for cardiac patients. And of course, when you do this, there is reduced requirement of allogenic transfusion in the post-operative period. So now we have completed the 4 important types of direct approaches: perioperative donation, acute normovolemic hemodilution, intraoperative blood salvage, and post-operative blood salvage. There are indirect approaches where we use various hemostatic agents, fibrinolytic agents, and others. The most important one amongst these is the tranexamic acid, which is an antifibrinolytic, which inhibits plasminogen activation and provides stabilization of clot. So when you use it, it is going to reduce the reduction in terms of blood losses and therefore reduce transfusion requirements. In fact, it is said all surgeries considered, if you think of all the surgeries where tranexamic acid has been tried, they found that the blood loss can come down by approximately 1/3. 30% of blood loss would come down if you take an average surgery where tranexamic acid has been used. And in fact, it is found that in orthopedic surgeries, the rate of allogenic blood transfusion, that is other than from the patient, is reduced by up to 69%, especially after hip and knee surgery, without increased risk of complications, including thromboembolic events. So overall, yes, we can give it orally, intra-articular, or in combination and IV. So because we are part of an acute event, we can always use it IV at 10 to 20 milligram per kg body weight. We can repeat it during intraoperative and postoperative phases based upon the different types of procedures. So as I told, this has been especially used in cardiac, spinal, orthopedic, prosthetic procedures, plastic surgeries, hysterectomy, and cesarean section. In fact, it is part of a WHO initiative to reduce the risk of postoperative bleeding in obstetric patients, post-normal delivery also. So it is a safe, cheap, effective agent, and you can use it routinely, and especially if there is an anticipated blood loss. And in fact, UK recommends for all the surgeries where blood loss is expected to be more than 500 ml, we should be giving tranexamic acid. Now, the small complication which has been assessed and against which you should be on guard is there can be higher risk of postoperative seizures with using tranexamic acid. Other drugs which have been tried, aporotinine was used for quite a long time, but it was removed from market in 2008. It is very good, especially in cardiac surgeries, in reducing the blood loss, but there is increased risk of cardiovascular complications. But epsilon aminocaproic acid is still being used. It is said that its efficacy could be similar to that of tranexamic acid overall, but it may be associated with increased risk of renal injury, and it is more widely used in United States as compared to Europe for the cardiac procedures. Erythropoiesis stimulants, as I mentioned in the beginning, erythropoietin can be used. It's an endogenous substance which is regulating the erythropoiesis, and its release, therefore, because it's a physiological response. Its release is stimulated by anemia and physiologic hypoxic events. So it is approved for usage in chemotherapy and CRF-induced anemia, clearly FDA approved. And it can be used in patients of preoperative anemia for surgery with significant risk of transfusion, and in perioperative autologous donation, which I spoke about in the beginning, because it reduces the need for allogenic blood along with the pre-op donation in adolescent, spine, orthopedic, or cardiac surgeries. There are other drugs which have also been tried in different sets of patients. Desmopressin, it has been mainly used in cardiac surgeries. Multiple evidences are there, but the supportive evidence are not that many. And it is found to be less effective than tranexamic acid. Fibrinogen, mainly with polytrauma or post-massive transfusion events, it can reduce the requirement of blood. And you have got prothrombin complex concentrates, 2 different varieties are available. It can be used in patients with congenital acquired vitamin K deficiency associated bleeding. So others, so just for completion's sake, I'm mentioning these agents. You have seen surgeons using certain fibrin sealants. Okay, so that might reduce the requirement of blood. We have gelatin thrombin or matrices. We got oxidized cellulose applied to the bleeding tissues during surgery, but generally they are expensive for the purpose, and the evidences are also very weak. And of course, vitamin K, where there is a known deficiency with respect to the clotting factors with large blood loss, there could be some contribution in terms of maintenance of the requirement of the blood for the patient. General measures, preoperative drugs, always iron deficiency anemia, we can administer iron to the patient. Then don't keep on drawing a lot of blood, especially in the pediatric patient. So if you keep on drawing blood, for example, from a 1-year-old child, okay, look at the volume in the particular in a patient, a child, or it could be, for example, maximum 400 ml or 500 ml. So drawing frequently the blood samples would itself result in anemia. We can always subject the patient for induced hypotension, hypotensive anesthesia, either as part of balanced anesthesia or general anesthesia, or we can even have central neuraxial blockades. And cautery, especially harmonic scalpel use, has been found to be better useful in terms of reducing the bleeding. Moderate hypothermia as part of myocardial protection is used in cardiac surgeries. And sometimes this is theoretical. Oxygen in the form of perfluorocarbons, etc., stroma-free hemoglobin and all, are the ones which may help in reducing the requirement of blood transfusion, and you conserve the native blood. So when you do all of these things, one thing which you should always be nowadays thinking about is using point of care testing. For example, using thromboelastography, rotational thromboelastometry, and platelet function assays. Why I have mentioned this is, these are the techniques which will help us to assess at which point of coagulation or the fibrinolysis there is a problem, and we can try to attend to those things at a local level, customized to the individual patient and the surgeon. So in summary, blood is a very critical organ and a very costly organ. In fact, blood transfusion is also referred to as an organ transplantation. And it's always very dangerous to use because there are so many risks related to the blood transfusion. So there is a need to reduce the usage of blood per se. Secondly, there are advanced techniques and technologies which are available nowadays, which will allow us to use lesser amount of blood, if at all, or reduce the requirement of blood in the perioperative period. What we can do is build up the patient's hemoglobin in the perioperative period, promote self-donation in the perioperative period, or provide acute normovolemic hemodilution, then compensate the patient with cristoids and colloids, or you can salvage the blood intraoperatively and postoperatively and use certain drugs, especially most promising has been tranexamic acid overall in multiple surgeries. So overall, it is a multimodal, multidisciplinary approach in terms of conservation of blood in the perioperative period. So these are the multiple references. Thank you very much for being patient in terms of listening to the presentation today. Thank you very much. I end my presentation.
Thank you, sir, for the excellent presentation. Sir has consented for the talk in a short period of time. Like we had decided about the topic just 1 week back only. Thank you so much, sir.
Thank you.
And sir, can we go to the questions in the chat box?
Yeah, I'm just saying.
One is how much ml of blood is drawn during an acute normoembolic hemodilution? I think you have explained it
Yeah, it's already mentioned. So basically, before talking about the exact volume, we also mentioned a formula for the patient in terms of acute normothermic hemodilution. So based on the patient's estimated blood volume and a target hematocrit of around 20 to 25%. So we can draw that much of blood in the patient where there is no contraindication, there are no cardiac comorbidities, which will prevent adequate compensation in that particular patient. So that's the condition. So there is a clear amount of volume. So I think that answers the question.
So another question is, does intraoperative blood salvage techniques amounts to hemolysis problems?
So normally it doesn't, basically, because there are the kits which are available. Because I went through all the details. There are disposable kits which cost around 8 to 10,000. Okay, so these are the kits which are used, and they also have the efficiency in terms of suctioning. So there is a reservoir bag, and to that reservoir bag, tubings are connected where you can pass a heparinase solution. Then we can pass a saline, and the debris can be filtered nicely. And hemolysis, of course, will not be so significant. It will be very minimal hemolysis, mainly probably attributable to the suctioning. It could not. It won't be something like the hemolysis which would possibly happen in cardiopulmonary bypass procedures, okay, where it goes through multiple multiple tubings, including oxygenators and other things. So those risks are not here. The hemolysis is very minimal, and the hemolyzed part is also ensured to be removed. So these are the advantages. There is not much of a problem. And there is another question, I think, from use of peritoneal blood in trauma patient when not having conservation unit. Yeah, filtration facility. So that's again difficult to comment upon, basically, because it's not ethical to. There is nothing called simple filtration. Take the blood from the suction and immediately transfuse. That is not accepted because it's open to the atmosphere in the operation theater. There is always a risk of infection. Basically, there could be some hemolyzed blood which is there. There could be some debris which is there. So all these things need to be filtered, then washed. Then heparin needs to be added. Heparin is compulsorily required to be added to the circuit. So that's the reason it should not be doing something like this. Directly picking up the peritoneal blood and pushing into the patient. Of course, these were discussed probably 3 to 4 decades ago. That there was something like this which was done, but they are not accepted in modern practice. And Dr. Venkatagiri has put a question: preoperative bleeding and transfusion, same is allowed in blood bank. Is there any procedure in blood bank? So preoperative bleeding is mainly the unit in terms of the preoperative autologous donation, because it is done days before. The blood is drawn from the patient and it is stored in the blood bank only, following the basic protocol of blood collection. But in terms of the intraoperative blood salvage, what is collected is transfused at the end of the surgery. So there is no need to go to the blood bank. So there are YouTube videos which show how this is done through the machine. It is kept and it can be transfused. But there is another option is the unwashed ones can be stored for about 6 hours at 4 degrees. That can be kept in the blood bank, and then just before transfusion, we can again rewash and transfuse to the patient. So that can happen. I think that answers my question, Dr. Giri.
No. What I asked is, blood bank, when we ask for give the oldest blood. Now that is what our banking technology. Is it that we say that it's for this particular person only I am bleeding? Because otherwise they say that you don't give. Anyway, he has to do all the tests. Agreed. But should we tell or anything like that? Because blood bank technology, they say that they will give the oldest blood, or the blood bank officer is the responsible and person decides what to give.
Yeah.
That's why I asked, is there any particularly, yes, we are giving for this purpose, his own blood, drawing under something we can say that. That's the only thing.
Yeah, no, because that principle is totally not part of a conservation, because it's patient's own blood. So it's autologous blood if it is preoperative donation, and intraoperative blood salvage is patient's own blood. So the very advantages of avoiding blood received from some other patient, that is allogenic transfusion, is totally removed. And preoperatively per se, patient is otherwise subjected to many of the viral markers and the hemogram and everything. So that problem is not there. And Dr. Majid, any blood investigations to be done routinely after these blood salvaging procedures are done. So actually the follow-up, as I said, is purely assuming that it is a good self-salvage unit. The self-salvage unit should be a quality one. We have got good brands which are there. So if they are used, they are very safe in terms of usage and they are not going to create any problem. But for intraoperative blood salvage, I mentioned about some things related to infection and cancer procedures. Okay, and there could be still rare risks of some sort of dissemination of cancer, number one, or some sort of infection which can still happen, or it could be some allo-immunization in pregnant patients, or there could be small risk of amniotic fluid embolism. And amniotic fluid embolism need not be volume dependent; it's quality dependent, and it can precipitate problems to the patient. But largely, evidences have shown that it is very safe. So, especially with respect to the multi-level spinal fusion surgeries, where it's more commonly used, cardiac procedures, and pediatric patients with craniosynostosis and obstetric patients, it has been very widely used. So, it has been found to be very safe, and there is no need to follow up with any investigation except than what is indicated in terms of clinical problems. A patient goes into some sort of hypotension, patient goes into some sort of allergic reactions in the postoperative period. Definitely, we can reinvestigate the patient in terms of blood investigations.
So in malignancy surgeries, unless there is a tumor rupture, you can use it, no?
Yeah. So that's what I was referring to.
Yeah.
I'm only suggesting the most unusual things that can happen. So no, we cannot say 100% the modern devices are proof of, in terms of efficiency, but there will be very, very small percentage of something like that happening. But evidences have shown that they are very safe in terms of modern practices, and it is widely used. And in fact, the requirement of allogenic transfusion has also drastically come down in those procedures. So that way they are very safe.
One question that blood washing, is that everywhere it is available or only particularly in a major hospital only? Washing and retransferring blood, whether any blood bank it can be done, or they have some special procedure for that?
Yeah. No, you will be surprised to know that it's not such a complicated thing. So only thing is, probably many of us in terms of the establishments are not mentally inclined to take up this type of approach. Even in cardiac surgeries, when we talk about cardiac surgeries, it is especially use of tranexamic acid and epsilon aminocapric acid and building up the patient's hemoglobin in the preoperative period. Greatly, the requirement of blood has come down. So what was being used in probably about 2 decades ago, the blood transfusion requirements and practical use of blood products in the preoperative period has come down, including in cardiac surgeries. So that way, there is never a requirement. And secondly, if you indeed anticipate that there are going to be loss of more than 4 pints of blood, definitely you can try to get this one of the disposable units which is available. As I told you, they would cost something like about 10,000 only for a patient for a single sitting. So avoiding allogenic blood transfusion and trying to get the benefit out of intraoperative blood salvage, definitely that cost doesn't appear to be costly. So we should be thinking about this technique to a greater level in our practice also. Of course, the initiative should come from both the surgeons group and the anesthetist group also. However, blood can be drawn before scheduled surgery. So one of the simplest concepts is we should remember how long the blood can be stored. Okay, so that lasts the duration of the RBC's life. So just like allogenic blood transfusion, so RBC life, if you take about 120 days approximately, it can be kept with the CPD and other things. But one important thing is the stored blood gradually, you'll have low levels of 2-3 dpg. It will not release the oxygen to the tissues immediately when it is transfused. So what we can try to do is at 4 to 8 week intervals, we can pick up 2 points of the patient's own blood, or One can be picked up about 2 to 4 weeks before, and another one can be up to 72 hours before the surgical procedures. So this can be a standard approach. 72 hours before, and at least 2 to 4 weeks before would be the first unit. So that is the way we can do without affecting the patient's hemoglobin and the ability to respond to an acute compensation in the perioperative period.
What is the minimum blood? Is there anything that if you are transfusing either 1, 2, 3, or otherwise you don't transfuse, the risk benefit ratio with the number of units transfused, and it said that if it is only one, because the some surgeons have the habit that yes, give 1 point blood. I always say there is no point in giving 1 point blood. There is no minimum. You have to give 2 or 3. What is that? How to make that? Because just for that, especially in the perioperative, transfuse 1 bottle, 2 bottles. There is no point in. The risk is more than the benefit. Is there anything or any guidelines for that?
See, broadly, we had become too restricted in terms of guidelines. It had gone to about 8 gram percent about 7 to 10 years ago. With respect to an average surgical procedure, where you can go up to 8 milligram percent, or something like an obstetric procedure, you can go to 7 milligram percent. That was a discussion about 10 years ago. But again, subsequent trials and investigations and evidences showed that we should see that the target is at least 9 to 10 gram percent. Don't allow the hemoglobin to go below 9 to 10 gram percent, and that could be the 9 grams could be the trigger point for transfusion. Number one. So one thing we can do is very simple is picking up the hemoglobin of the patient and trying to assess. Number one. Number two is a rule of thumb all of us have read for ages together. If blood loss is more than 20% of the estimated blood volume in an adult, so up to 20%, we can always replace them with crystalloids or colloids or a combination of the two. Anything beyond 20%, we would be required to transfuse the blood products only for the patient. The third concept is with respect to the maximum allowable blood loss, MABL. I'm putting it in a perspective from the purely based upon hemoglobin. Number two, based upon the acceptable in terms of the volume as 20%. And number three, basically as MABL for a particular patient. So if you anticipate certain blood loss in a major procedure, so based upon the target hemoglobin and the initial hemoglobin or hematocrit multiplied by the estimated blood volume of the patient, you will get the volume that can be lost. So you should be able to calculate the amount of blood lost intraoperatively, either by gravimetric method or calorimetric method. 2 techniques broadly are available. If you are able to assess the estimated blood loss, so if you think a patient has got a MABL of up to 1000 ml, and if you find that the blood loss is intraoperatively is around 800 ml, so there is no need to transfuse for the patient. So if it goes to about 1200 ml, means you have to transfuse blood to the patient, at least the 200 ml volume. So this is the third concept. The three of these things can be followed for the patient. And of course, I am not, this cannot be applicable to an ongoing bleeding, a major trauma. Okay, so we cannot, the assessment should be on a continual basis.
Thank you, sir.
Yeah.
What is your experience with the factor R7R, sir?
Factor?
R7R in acute bleeding.
Yeah, we don't have much experience in that, I must admit. But thing is, we can always use them. Some of the pediatric patients and medical patients, it is being administered. I don't have an experience, personal experience with that.
Okay, thank you, sir.
Dr. Muralidhar Kanchi has made some comments. Dr. Muralidhar Kanchi,
Yes, sir. Can I unmute and
Sorry, sir. Yes, sir. Compared with, sir, are you there?
Dr. Muralidhar Kanchi? Sir can unmute and
what he has written is, compared with allogenic blood transfusion, intraoperative blood salvage seems to be a good way, except in tumor operation, as he said. Yes, sir has rightly pointed out, as with respect to the care we should exercise during tumor surgeries, monitoring of plasma hemoglobin may be useful to avoid the risk of acute kidney injury. So that's an important comment sir has made. As I said, in response to Dr. Venkatesh's question, we can get the hemoglobin done intraoperatively in the patient's blood And based on that, we can also decide on administration. And of course, there was some mention of hemolysis and risk of, whenever there is hemolysis, there is a risk of acute kidney injury also. But they said all of them are possibilities, but mainly because of the improvement in the delivery systems and the filtration, everything, and lipo reduction in cancer procedures, the complications and risks have drastically come down.
Okay, sir. Thank you.
Rajesh sir, we appreciate the presence of many seniors.
Yeah.
They can unmute and give their comments if they want.
Dr. Vijayanand is
Only
there.
sir, if you are available, please unmute.
Yeah, happy to see Dr. Chakrarao sir. Good evening.
Good evening, namaste. I'm having another meeting of IRC.
Yes.
So we are now on digital platform.
After this.
So I'm little late. Otherwise, I wanted to see your lecture from the beginning. Thank you very much.
And Dr. Agnihotri sir is there.
Thank you, sir. If there is no more comments and questions, shall we move on to our next session, sir?
Dr. Balbaskar, sir, why this salvaging procedure is not common in India?
I cannot say it is not common. I have heard about it being used mainly in major orthopedic establishments and cardiac centers. So, for example,
nowadays it's used for liver transplant procedures also, sir.
Definitely liver transplant procedures. So they are being used, and probably one of the things is in terms of overall improvement, even in the policy of allogenic transfusion. That's the reason I refer to the guidelines. The guidelines themselves have become more restrictive nowadays. So you build up the patient's hemoglobin in the preoperative period, better surgical procedures in the intraoperative period, and tranexamic acid. That's why I said it's probably one of the revolutionary drugs which is available. And in fact, we are underutilizing tranexamic acid itself, let alone talk about intraoperative blood salvage. Tranexamic acid, I think it is grossly underutilized. So we can be using more and more of tranexamic acid. And Dr. Vijayanand, I do have inputs from institutions like CMC and some other institutions in Mumbai. They have been using it, and it has got a good potential.
Yes, sir, because
Probably a topic less discussed, I think.
Because Dr. Venkateswaran sir was asking whether
Yeah.
it can be used in the district hospitals or only in the selected centers. That's the point I was asking you, sir.
Yeah, but that's the reason I told. Cost-wise, it's not a problem. Technique-wise, it's not a problem. When I went through the various presentations from Western literature also, technique-wise also, there is not much of a problem. All of us would be competent enough to use this technique. Only thing is, there is a delay in starting. At least all of us are exposed to, cesarean section patients, polytrauma patients, where there is sudden acute hemorrhage, bleeding. So those are the conditions where we can definitely use this intraoperative blood salvage.
May I ask Pala Bhaskar?
Yes, sir. Good evening, sir.
Good evening.
Yes,
My
sir.
question is very particular about this thing.
Yes, sir.
How far the blood conservation is accepted in big institution? Because nowadays it's the topic of the transfusion services. They are responsible for all these things. You have to send only the requisitions to all these factors to them. And
Sir,
secondly, is there any new concept about the filtration of the long bone injury in which the fat cells are transmitted and they can be filtered before giving retransfusion?
Yes, sir. Thank you, sir. So, first, number one is in terms of experience in the Western countries. They are widely used, and in fact, it has become such a concept that lay public, the patients are asking the institutes whether they can avoid the allogenic blood transfusions. So voluntarily, the hospital administrations would discuss with the patient whether they'll be able to or ready to donate their own blood for their own use. So to that extent, the knowledge has percolated in Western countries, and deliberately there are teams which are available. They will discuss with the patient in the preoperative period and take it up. So that much is the application of this technology and the concept in the Western countries.
Yes.
So in Indian conditions, basically, as we are discussing in the last few minutes, there is a need, and it has been used in some other institutions. And probably one of the things that has, two things would have happened. One is they are already happy with the current outcomes in terms of the patient's morbidity and mortality with allogenic transfusions and the use of drugs like tranexamic acid.
Yes.
Number two, probably they are a little bit hesitant to take up this technique. So this is the two reasons I think about the
Yes.
technique. And the second part, definitely the filtration mechanism has improved. The viral transmission also would be reduced, apart from bacterial transmission of infection. So largely, that's why I said if we do subject the test for screening for HIV, HPSAG, HPA1C, and everything. Sorry, hepatitis C and everything nowadays. It is found that it is safe nowadays. Laboratories are also better equipped to detect these, and the blood transfusion practices and the policies of the government of India is also very strict. So they are subjected to various tests, and even during the transfusion of allogenic blood, there is no risk of infection. But when you talk about autologous transfusion, in that also the filtration and the removal of infection is also taken care of, especially for cancer procedures, because they already have got immune suppression.
Thank
so
you.
Very careful in those patients.
Thank you.
Thank you, sir, for the excellent presentation, and thank you everyone for the active participation and the questions and discussions.
Thank you.
Over to Dr. Binil for the.
Thank you, Dr. Rajesh, and I thank Dr. Balavaskar for excellent presentation. Thank you, sir. You have covered almost all the sessions of perioperative blood salvages. Now we will move on to our next session, that is PG Corner. Today we will discuss tranexamic acid and difficult airway trolling. To moderate the session, I welcome Dr. Deepa, Senior Consultant from Baby Memorial Hospital, Calicut. Over to Dr. Deepa.
Hello, am I audible?
Yeah, you are audible.
Hello. Oh, good evening to one and all of the organizers, especially the esteemed guest of the today evening, Dr. Balavaskar, sir. Thank you, sir, so much for the excellent presentation that you have given to us, an informative talk indeed. And I thank on behalf of the BMH, that is Baby Memorial Hospital, Department of Anesthesia, for the ISA, to the ISA Kerala State Chapter, especially Shamshad Madam, Binil sir, Paul sir, and the others for having given us the opportunity to present in this platform. Two of our postgraduate students, Dr. Farida, she's a secondary DNB postgraduate. She's going to present on the difficult airway trolley. And the other one, the second topic of discussion will be tranexamic acid. A brief description of it was given by Dr. Balavaskar sir also. It will be presented by Dr. Sana Malik. She is a primary DNB student in our Baby Memorial Hospital. Thank you so much, sir, and to the ISA Kerala State Chapter once again for having given us this opportunity. Over to Dr. Farida to present difficult airway trolley.
Okay, madam. Okay, ma'am, shall I start?
Yes. Yes, you can.
Respected teachers and dear friends, I am Dr. Farida. I am here to present a topic on difficult airway cut. As you all know, securing and maintaining a definitive airway is the foremost responsibility of an anesthesiologist. So, it is an integral part of general anesthesia, allowing ventilation and oxygenation. So, before going to the difficult airway cut proper, let's see what is difficult airway. What is difficult airway? As per American Society of Anesthesiology, they define the difficult airway as a clinical situation in which a conventionally trained anesthesiologist experiences difficulty with bag and mask ventilation or endotracheal intubation or both. So this difficult airway spectrum include difficult ventilation, difficult laryngoscopy, difficult intubation, and difficult tracheostomy. So we have so many guidelines regarding this difficult airway management. We have DAS guidelines, that is Difficult Airway Society guidelines, and AADA guidelines, that is All India Difficult Airway Association, and also we have ASA guideline, American Society of Anesthesiology. So severe morbidity and mortality attributable to anesthesia is mainly due to failed difficult airway management. So whenever an airway emergency arises, there should be an immediately access to the difficult airway equipment. That is crucial for the implementation of rescue strategy. So here comes to the importance of difficult airway trolley. Difficult airway trolley or a cart is nothing but a cart which contains the equipments for the management of both anticipated and unanticipated difficult airway. It allows easily and timely access to the necessary equipment that is required in emergency situation, and also it acts as a visual guide how to prompt through a difficult airway strategy by the clearly labeled drawers. Ideally, there should be one difficult airway cart per area where the anesthesia is delivered, and anesthetist should know what to find in each drawer whenever an airway emergency arises. So let's see what are the features of an ideal difficult airway cart. It should have a top work surface and should have a 4 to 5 drawers which is clearly labeled and arranged in a logical sequence, and it should be mobile, easily reproducible, and easily cleanable, and it should have a attached documentation of these guidelines and local algorithms. So top surface with the 4 to 5 drawers should be mobile, it should be robust, it should be stocked in a logical sequence, and should have attached documentation of DAS or modified local guidelines, and checklist for restocking and logbook for daily checking. So before moving to the contents of the difficult airway trolley, we need to have an overview of difficult airway guidelines, that is difficult airway algorithm by these 2 guidelines, because the contents of each drawer is corresponding to the specific plan, that is specific airway strategy of these guidelines. So let's have a look into this. This is about the DAS guidelines. The plan A, first step is face mask ventilation and initial tracheal intubation. If there is a failed intubation, the next plan is maintaining the oxygenation by supraglottic airway device. If there is a failed difficult supraglottic airway device failed ventilation by a supraglottic airway device, the next plan is maintaining the oxygenation by face mask ventilation. If both ventilation and intubation fail, it is considered as cannot intubate, cannot oxygenate condition. In that case, we need to have emergency cricothyrotomy, either by surgical cricothyrotomy or by needle cricothyrotomy. So the plan A, which is face mask ventilation and initial tracheal intubation, the contents. So the contents, the plan A, which is corresponding to drawer 1. The plan B, which is SAD insertion, that's correspond to drawer 2. The plan C is face mask ventilation, that's correspond to drawer 3. And the plan D, which is cricothyrotomy, that's correspond to drawer 4 and 5, that is suggested by the DAS guidelines. So I already told this difficult airway trolley as a top surface, it has 4 to 5 drawers, and it also got top sides. So let's have the contents of the trolley. On the top of the surface, we have flexible intubating fibroscope, either in the form of portable scope with the battery light source, or a portable stack system, that is STORS telepack system, or single-use fibroscope, example ambuscope. This is the portable scope with battery light source. This is STORS telepack system. In this, all in a one system, which contain monitors, LED light source, full HD camera, and control unit, and the documentation, all in a one system, that is telepack system. This is the single-use fibroscope, that is ambuscope. That's a content in the top of the trolley. Then we have on the side of the trolley, we have both adult and pediatric bougie, entry intubation catheter, and airway exchange catheter. This is the bougie. This is the picture of the bougie. This is an airway introducer in order to facilitate the endotracheal intubation. And also, we can introduce this through a poorly visualized laryngeal inlet. This is picture of the airway exchange catheter. As the name indicates, it is used for exchange of both endotracheal tube and supraglottic airway device. Behalf of that, we can ventilate through this port by either by insufflation or by jet ventilation. So it is used in difficult airway management. This is the entry intubation catheter. It is nothing but just a modification of entry airway exchange catheter with a large internal diameter, and we can it is designed to use with fiber optic bronchoscope in order to facilitate endotracheal intubation or SAD insertion. Then we have drawer 1 that's correspond to plan A. The plan A is optimize the head position, introduce the bougie, and use alternate laryngoscope. So the contents include alternate laryngoscope, that is short-handed laryngoscope, video laryngoscope, and different types of blade like McCoy straight blade. So with these are the pictures of the McCoy blade, McCoy laryngoscope, short-handed laryngoscope. This is all to facilitate the view of laryngeal laryngoscopy. The next is the drawer 2, which correspond to plan B, that is maintaining the oxygenation by supraglottic airway device. So the contents include various types of supraglottic airway device, that is classical LMA size 345, second generation devices 345, and intubating LMA 345. And also it is followed by fiber optic tracheal intubation through the LMA. So the fiber optic adjuvants also included in this drawer 2. Either we can, these are the pictures of classic LMA, iGel, and fast track LMA or intubating LMA. So fiber optic adjuvants, either we have the Berman airway or Ovasapien airway and mucosal atomization device, different preparations of local anesthetic, lignocaine local anesthetic, either 2%, 4%, and 10%, and instillagel spray, instillagel gel, and cophenylcaine. These are all for the topicalization of airway for awake fiber optic intubation. So the fiber optic adjuvants include Berman airway, Ovasapien airway, mucosal atomization device, nasal sponge, 4% lignocaine, 10% lignocaine, instagel, cophenylcaine. Either it can be stored in the drawer 2 or it can be stored as a separate storage box which accompany the trolley. That's all about the drawer 1 and drawer 2. And next the drawer 3, which is correspond to plan B. The plan B, plan C. So the plan C is bag and mask ventilation. That is, so the contents include different types of face mask and also the airway adjuncts, that is various sizes of oropharyngeal airways and esopharyngeal airway in order to maintain the patency of the airway. And also the Prosil LMA size 345 also included in the drawer 3. Then about the drawer 4, that is correspond to drawer 4, that corresponds to plan D. The plan D is surgical cricothyroidotomy. This surgical cricothyroidotomy is performed in a way that the patient is in the supine position with a neck extended position and place a stab incision through the number 10 scalpel in cricothyroid membrane and pierce the cricothyroid membrane and turn the scalpel into a 90-degree chordate and then place a bougie through this and through the bougie railroad the endotracheal tube size 6 and 7. So the content of the drawer 4, which is correspond to the equipments needed for surgical cricothyroidotomy, that is large bore cannula device, number 10 scalpel, tracheal dilator or tracheal hook, and bougie, and also the tracheal tube size 6 and 7. Then about the cannula, drawer 5, that's correspond to plan D, that's by cannula cricothyroidotomy. It is performed by putting a puncture in the cannula at the cricothyroid membrane and connect the cannula to a jet ventilation system or oxygen insufflation system. So the contents include King Reston jet ventilation cannula or high pressure, low pressure ventilation system. This is the Manujet 3 and this is the high pressure jet ventilation cannula Rousing. So also we have miscellaneous contents in the difficult airway trolley, which include DAS intubation guidelines or locally agreed algorithm, and also the equipment checklist for restocking, and also the logbook for daily checking procedures may also have extubation guidelines. So this is the setting up of the difficult airway trolley by DAS guidelines. This is only a guide, what all content should be there in the difficult airway trolley and how to arrange these equipments in the trolley. But this is not considered as an absolute recommendation by Difficult Airway Society. Then we have looked into the AADA recommendation. This plan is same. The step 1 is laryngoscopy and tracheal intubation. The step 2 is insert the SID to maintain the oxygenation. And step 3 is maintaining the face mask ventilation. If both ventilation and intubation fails, that is by managed by emergency cricothyroidectomy. This is the unanticipated difficult airway intubation guidelines in adult by AADA. So AADA have many recommendations regarding this difficult airway trolley. They have no consensus regarding which all equipment should be there in the difficult airway cart, but the available equipment that should be familiar to the user and standardized according to the local protocol. It should be a permanent movable storage space with at least 5 to 6 drawers or compartment. Either it can be a trolley or a bag or a cart in addition to the emergency drug trolley. There can be individual variation according to the local requirement, and it should be checked at least once a day and following every use. And the side of the trolley should have a list of contents of daily check. These equipments in the difficult airway cart is in addition to the equipments for suctioning, capnography, and other monitoring devices. So the AADA recommends a list of mandatory equipments that is include working laryngoscope with Macintosh plate, face mask, endotracheal tube, Magel's forceps, stillite, bougie, different airways, oropharyngeal airway and esopharyngeal airway, manual self-inflating bag, the cannula or catheter or other device to supplement the jet ventilation, and also the cricothyrotomy device and airway exchange catheter and different types of supraglottic airway device. So this is the setting up of the difficult airway trolley recommended by AADA, which has got slight variation as compared to the DAS guidelines. So in this, we can see only 4 drawers present and all the drawers which is corresponding to specific management plan as by DAS also. So with slight variations like the face mask, which is included in the drawer 1 in this and which was in the drawer 3 as per DAS, and slight variation. I already told these guidelines are not recommend. This is absolute recommendation by these guidelines. This is just a guide how to set up a difficult airway trolley and what all content should be there whenever an airway emergency arises. That's all. So the important one is how to label the drawers of each content, because a clearly labeled drawers which act as a visual prompt in that emergency situation, how to progress through a difficult airway management strategy. So the drawer label that can be customized as required to illustrate the particular type of equipments present in the various drawers, and the specific make and model of the equipment should be agreed locally, with regular, comprehensive and continued training provided for all relevant staff. This is the just suggestion by the Difficult Airway Society how to label each drawers, so that we can easily progress through a difficult airway management strategy by looking at these clearly labeled drawers. So what is most important is providing the right equipment in the right amount, in the right place at the right time. That's all about my presentation. These are my references, and thank you.
Thank you, Dr. Farida, and over to Dr. Deepak.
Farida, thanks a lot. It was a good presentation. Any questions, please, from the audience?
She presented very nicely and she covered all the aspects of a difficult airway guidelines as well as the trolley.
Yes.
So there is no question to ask to her. So that's how she presented. She's nicely presented.
Thank you so much, Shamsud, madam. Thank you, madam. So then I think we can go to the next topic.
Yeah, we will move on to next topic, the second topic. that
Yeah,
is
so then over to Sana Malik. She's going to present on tranexamic acid. Yes, Sana, please start.
A warm good evening to one and all, respected teachers, seniors, and all my dear friends. Today, I'm here to talk a few words on the drug tranexamic acid. We all know that clinically significant bleeding can occur during surgery, trauma, obstetric complications, anticoagulation, and in disorders of hemostasis. Many times the cause of bleeding are diverse and not always immediately apparent. Thus, the availability of a safe, effective, and non-specific hemostatic agent becomes vital. Tranexamic acid was synthesized in 1962 by Japanese researchers Shosuke and Utako and is one of the most commonly used and widely researched antifibrinolytic agent. It is now listed in WHO's list of essential medicines. Coming to the mechanism of action of tranexamic acid, it is a synthetic derivative of amino acid lysine, which competitively inhibit the lysine binding site of plasminogen. Thereby, it inhibits the degradation of fibrin to fibrin-degraded products, which accounts for its antifibrinolytic action. The tranexamic acid also inhibits plasmin-mediated activation of neutrophils, monocytes, and complement system, which accounts for its anti-inflammatory property. Coming to the pharmacokinetics of tranexamic acid, it can be given as orally, intravenous, intramuscular, and topical. The half-life of tranexamic acid is 2 to 11 hours. The onset of action with single oral administration is 1 to 5 hours with a mean of 2.5 hours, and the duration of action is for 3 hours. 95% excretion of tranexamic acid occurs through urine. Thus, we recommend dose reduction in renally impaired patients. No dose adjustment is recommended with hepatic disease, and it belongs to pregnancy category B. That is, no harm has been demonstrated in human studies, but no or small risk was seen with animal studies. Exposure to infant via breast milk occur, but it occurs to such a low concentration that we recommend continuation of tranexamic acid in lactating mothers. The different modes of administration of tranexamic acid and its preparations, they are available as oral 500 mg tablets. Intravenous, they are available as 5 ml ampules with a strength of 100 mg per ml. And topically, they are available as 5 ml, 10 ml, 50 ml vials with a strength of 100 mg per ml. The two major trials in the field of tranexamic acid was the CRASH-2 trial, which was a randomized controlled trial of 2010, which shows significant reduction in mortality when tranexamic acid was given within 3 hours of acute trauma. And the women trial of 2017 and women trial of 2017, which was conducted, which was also a randomized control trial conducted among 20,000 women with postpartum hemorrhage, which showed 33% reduction in maternal mortality when tranexamic acid was given within 3 hours of childbirth. Now, coming to the uses of tranexamic acid, the only FDA approved use of tranexamic acid is for heavy menstrual bleeding. The first use of tranexamic acid was also in females for heavy menstrual bleeding. We recommend an oral dose of tranexamic acid of 1 to 1.5 milligram divided over 3 doses for 5 days. And short-term prevention in patients with hemophilia undergoing dental extraction, the dose recommended is IV 10 mg per kg immediately before surgery, then oral 10 mg per kg 3 to 4 times daily after the procedures. Many studies have been done with tranexamic acid, which has led to its off-label, which showed significant reduction in the bleeding rates and has led to its off-label intravenous, oral, and topical tranexamic uses. Coming to the off-label uses of intravenous tranexamic acid, it is now commonly used in severely bleeding patients who meet the massive transfusion protocol or in where hyperfibrinolysis is demonstrated. The CRASH 2 trial and the women trial form the basis for this. The recommended adult dose being 1 gram bolus in 100 ml NS over 10 minutes, slow IV, and a repeated dose of 1 gram over 8 hours. It should be noted that the total dose should not exceed 2 gram. In pediatric age group, a weight-based initial dose of 20 mg per kg, IV bolus over 10 minutes, and a repeat dose of 10 mg per kg hour over next 8 hours. Now, the studies with IV tranexamic acid in surgical operation has led to significant reduction in bleeding, and we recommend its use in elective cesarean section, that is IV tranexamic acid, 1 gram over 5 minutes, at least 10 minutes before skin incision. In cardiac surgeries, the initial studies were conducted with a high dose of 100 mg per kg. Though they demonstrated reduced bleeding, there were increased incidence of post-operative seizures. So the further studies with reduced dose were conducted, and an IV dose of 50 mg per kg after 30 minutes of anesthesia has been recommended. It reduced bleeding rate in cardiac surgeries without increasing the thrombotic event. And it also has a role in reducing the inflammatory responses following cardiopulmonary bypass. In unilateral, bilateral knee replacement, hip replacement surgeries, and also hip fracture surgeries, IV tranexamic acid of 10 to 15 milligram per kg over 10 minutes before deflation of the first tourniquet and 3 hours later has led to significant reduction in the bleeding rate and also have reduced the transfusion requirement in these patients. In spinal surgeries, IV tranexamic acid with a dose of 2 gram over 20 minutes before skin incision, followed by 10 mg per hour during surgeries and continued 5 hours post-operatively, reduced the bleeding rate in surgeries involving 3 or more vertebrae. Many more studies has been done in the field of upper GI bleeds, neurosurgery, liver surgeries, and ENT FES surgeries. But the Cochrane reviews of 2012-2013 does not recommend the routine use of tranexamic acid in these fields, as there is lack of data regarding other outcomes, its efficacy versus other intervention. In neurosurgeries, there have been 2 suggestions of intravenous tranexamic acid. One being as a reversal agent of intracranial bleed caused due to thrombolytic agents. Along with cryoprecipitate, or when cryoprecipitate is not available immediately. And in the other being non-traumatic subarachnoid hemorrhage, the tranexamic acid, though showed reduction in the bleeding rate, delayed brain injury due to microthrombi formation was reported. Thus, routine recommendation is still not coming. Now, coming to the off-label uses of oral tranexamic acid. Post-procedural after cervical conization, 1 gram intravenous tranexamic acid during procedure, followed by 1 gram oral tranexamic acid 3 times a day post-procedurally for 14 days has reduced the bleeding. In hereditary angioedema, oral tranexamic acid is recommended as the 3rd long-term prophylactic agent. When C1 esterase inhibitor is not available or when androgen being contraindicated, oral dose of 1 to 1.5 gram can be given 2 to 3 times initially. And with reduction in the frequency of attack, the dose can be reduced to 500 mg per dose. In transurethral resection of prostate, oral 2 gram tranexamic acid 3 times daily and first day after surgery revealed reduced intraoperative blood loss. Studies with intravenous tranexamic acid has been done with TURP, which reduced the loss of hemoglobin, reduction in the loss of hemoglobin per gram of prostate tissue, but concern still remains regarding the retention of clot. So, routine IV administration of tranexamic acid is still not recommended with TURP. Tooth extraction in patients on anticoagulation like warfarin. Oral rinse of 10 ml, 4.8% solution of tranexamic acid 1 hour before the procedure had reduced the bleeding rate. It can be controlled post-procedurally for 4 days. Use of topical tranexamic acid. In traumatic hyphema, it has reduced the secondary bleeding rate. In nose bleeds, anterior nasal pack with tranexamic acid has reduced the bleeding, rebleeding, emergency department times, and also increased the patient satisfaction. In hemoptysis, nebulization with 1 gram tranexamic acid in 20 ml normal saline has reduced this incidence. Nowadays, topical tranexamic acid is also being used for hyperpigmentation. Here it is said that the tranexamic acid inhibits the synthesis of melanin and also it transfer from the basal layer to the superficial skin layer. Now coming to the adverse effect of tranexamic acid, the most common side effect being hypotension, which can be tackled with slow IV infusion. Seizure is a dose-dependent side effect of tranexamic acid, which is usually seen in higher doses. The mechanism of how tranexamic acid causes seizure is not well known, but some studies have said that it can inhibit the GABA channels in the brain, resulting in increased neuronal activity. The other side effects being headache, backache, GI symptoms like nausea, vomiting, abdominal pain, diarrhea, fatigue, pulmonary embolism, deep vein thrombosis, impaired color vision and other visual disturbance, as it can cause central retinal vein venostasis, resulting in retinopathy. Contraindications to tranexamic acid be known allergy to tranexamic acid, intracranial bleeding, history of arterial or venal thromboembolism or active thromboembolism more than 3 hours after trauma, and also in acute coronary syndromes. We recommend we do not recommend the use of tranexamic acid in patients who have underwent angioplasty with stent for about 6 months till the endothelization completes. As Sir have already said in his earlier presentation, tranexamic acid can also be used as a post-op to prevent the bleeding loss during surgery and can be recommended in surgeries where we see more than 500 ml lead loss. Thank you. Over to you, Deepa ma'am.
Thank you so much, Sana, for the presentation. It was a good presentation. Over to the audience for any questions to Sana.
Excellent presentation by Sana. It was a detailed presentation by both of your PGs.
Thank you so much, sir.
Shamshat madam, please unmute.
Usually the gynec people are recommending tranexamic acid nowadays for all cases, especially after pregnancy and all. And she nicely described everything. So any other questions? I don't have any questions because they have explained all the facts and also all the details very nicely. And I have to congratulate Deepa as well as Rajesh for preparing their talk as well as the training, and also they were very nicely talking.
Thank you so much, ma'am.
It's really useful, useful topics, both. And also the Balabhaskar sir's talk followed by this tranexamic acid. That has covered all the aspects of the significance of this blood transfusion.
Thank you, madam. They have done it in a very short time.
Yeah. What Rajesh, I haven't heard.
They have done it in a very short time. 6 days or 7 days. Yeah, 1 week. Of course, Farida used to present. She's a secondary candidate, but Sana is a primary candidate. She also did well, both of them.
Yeah.
But both of them are very enthusiastic students.
If seniors, if there is any questions, they can unmute and ask the questions. Giri sir.
Sudesh was there. He left, no? Sudesh Kannan.
Yeah, Sudesh left.
I can see him here. I think he left.
Sir also left, I
Sir
think
also-
so.
Balavaskar
Balavaskar
also
sir
left.
also left.
Meanwhile, a reminder on behalf of ISA Sarka AA Congress 2022 team. Sarka AA Congress 2022 will be held on 12th, 13th, and 14th. That will be next Friday, Saturday, and Sunday. I invite all our participants to Sarka, which will be held at Cochin. So please do attend the conference. It will be what do you call it? It will be a heart-touching experience for all of you.
It's a rare chance for all of us to attend an international conference. That's what I feel. Especially for Sarka, only the great leaders of our ISA is attending. So this time we all can attend. Rajesh?
Yes, madam.
Rajesh.
Can we close the session? There is no more questions. We'll see you at Sarka.
Okay.
So over to Madam for
Thanks.
last procedure, that is vote of thanks.
You can. On behalf of Paul Vinalkar.
Thank you, Madam.
Thanks.
So I express my sincere thanks to today's speakers, Dr. Balavaskar. In his absence, I thank sir for giving an excellent presentation. Sir, actually, sir covered almost all the areas of blood preservation before surgery. Thank you, sir. And I also extend my sincere thanks to Dr. Deepa for moderating the PG Corner session. And I thank Dr. Sana and Dr. Farida for presenting excellent topics like tranexamic acid and difficult airway trolley. They have done very well, actually. Actually, I was not expecting up to that level from a PG, but it was excellent.
And now
I
Venkatesha has joined. Whether he has any questions.